and then we'll make a start. So I should introduce myself. My name's Geoff Underwood, and I'm a Programme Director at South Central and West Commissioning Support. And I worked on the piece of work we're going to talk about with Richard, our guest, and BSW Together ICS for the best part of a year. We're excited to be talking through this with you, and this is for any of you who are at the Confed conference in Liverpool this year. This is we gave this presentation there and had a really good discussion afterwards, so hoping to repeat that again today. I'll now introduce our guest. We're really delighted to be joined by Richard Smale. Richard, I'll let you introduce yourself, and then I'll click through the first few slides for you. So over to you, Richard.
Thank you, Geoff, and good afternoon, everyone. Thanks for joining the session. I hope you find it valuable. So my name is Richard Smale. Some of you may know me, some of you may not. So I'm the Director of Strategy and Transformation for the BANES, Swindon and Wiltshire Integrated Care Board. I've obviously been in that role only for a couple of months since we formed in July, but I was actually working in the system previously in a strategy and transformation role for a couple of years. So what I'm just going to chat through quickly before Geoff goes through the detail of what we really did is a little bit of why we did it and how we started the process, and then I'll hand over to Geoff. But thinking about why we did this piece of work, for years I've sat in health and care systems where we talk about we need to do more in the community. We need to do more about integration of services. Can we just remind people to go on mute if you have just joined the call? Thank you. Talk about sort of the way services are integrated. We talk about, you know, phrases like shift resources left have been bandied around for a long time. And, you know, lots about tackling inequalities. And I think, you know, at the heart of this piece of work was the fact that we often talk about those things, but we often talk about them with a slightly different lens, a slightly different perspective, slightly different mindset when we're talking about them. And what we were trying to do through this piece of work is bring people together around a common theme, really. So that's setting the scene. Just a little bit on that slide there about the background to what BSW is. It's a relatively small integrated care system, 920,000 people. So when you compare it to some of the size of the other ones, it's a smaller one. But it's got a large landmass. It's got a large landmass, mainly based in Wiltshire. About 80% of our geography is in Wiltshire. Quite a rural population, quite an ageing population. Some real affluence, but some real deprivation as well within our system. So we've got, you know, a decent proportion of our population live in the more wealthy areas, but there are some real areas of deprivation in sort of central Bath, in parts of Swindon, and out in some of the rural communities. We work with 3 local authorities, so we have to work in a way that recognises and respects the local democracy that goes on in 3 local authorities and the sort of policies and frameworks that are there. And that's an important bit of who we are. And we also have 3 acute hospitals, all of whom are on the outer boundary of our system. So in a way, we're not an actual system. We have lots of flows in and out of our system for specialist and acute services. And that creates different challenges and different questions for us. But Geoff, if you can click us on to the next slide. So what we began the sort of question with is anywhere getting this right? Is anywhere doing better than us? Is there somewhere in the world that we could learn from and look at? And what we began to do with some work supported by KPMG, as it happens at the time, was we looked at Israel as a system. And we began to ask the question, you know, what is it that is helping Israel to achieve good outcomes for its population, to achieve good productivity in the way it delivers services, and really achieve results that other health and care systems are not doing as well on. And that was a sort of benchmark of what we began with. And we began looking at that with parts of our system. And then over the coming year, we developed that conversation more and more to say, OK, well, that's interesting what Israel do. What would that mean for us? And I'm going to hand over probably at that point to you, Geoff, to say, if you tell the story of what you did and the work you helped coordinate, and we'll come back to me at the end. Thanks.
Thanks, Richard. So the work started off, as Richard said, I joined a project that was being supported by KPMG in the Bath and North East Somerset part of the BSW system, to develop a future model of care. And so we did. We developed, if I go on to the next slide, this is the model of care we developed in Bath and North East Somerset around May, June 2021. This was the draft we came up with, and I took this model of care around to the other two places in the BSW system, that's Swindon and Wiltshire, to get some feedback on it. And so people were keen to sort of get their teeth into this model, and we could talk about that in a moment. But what I heard in Swindon and Wiltshire was, well, hang on a moment, we've actually got one of these as well in Swindon and Wiltshire. We've been working on this ourselves. Why don't we come up with a single model of care for the whole integrated care system? Because, you know, after all, aren't we supposed to be part of one big system? So that's what the project then became, taking this model in Bath and North East Somerset and the two models I'll talk through for a moment in Swindon and Wiltshire, and then coming up with one model that could summarise the best parts of all of them and could unite the integrated care system around one shared vision. So we started by talking about the model from Bath and North East Somerset. And there were things that people really liked about this. They liked the idea of the sort of themes in the boxes. So going from the top left, a theme around prevention and population health management, a theme around enhancing out of hospital care, reaching out from acute trusts, a theme around improving community-based care and escalation. So, you know, keeping people out of hospital in the first place. And particularly the box on the bottom right about developing hospitals of the future. As Richard said, there's a lot of conversation about shifting things left, or, you know, what sort of things should we be not doing in hospitals? And that's, I guess, a sort of negative way of framing it. And we wanted to switch it around and say, well, what are the things we absolutely should be doing in hospitals in the future? And how do we make sure we're focusing our specialist centres on those things? So there were things about this model that people liked. I think people thought it was pretty complicated to look at, people like the idea of about building it around a central point, but people weren't sure whether a single point of access or a coordination service was the right sort of thing to have in the middle. So then we looked at the model that Swindon had developed, and again, it's quite a kind of technical schematic kind of model. This was developed in 2017, I think. So because of that, there are a few things you might expect to see in 2021 when we were doing the work that aren't on this. So, for example, it doesn't mention population health management, but nobody was talking about population health management in 2017. Things that people really liked in this model, particularly the people who've done the work in Swindon, were the little apples that you see dotted around a picture, indicating that prevention should be part of everything all over the model. People like the idea of technology wrapping around things, so you can see that kind of blue rectangle of technology wrapping around and linking things together. Again, there's a coordination sort of idea in the middle, the clinical hub coordinating things, which people like the idea of kind of having something in the middle, weren't sure about that. And there is a bit of a sense of how things might flow around the system with the various hours and things. But again, people thought it's quite complicated. There's lots there, and potentially quite a lot of healthcare terminology. And would this really be accessible if you were, you know, a member of the public looking at this? And then finally, we looked at the model that Wiltshire drafted, and this one was slightly different. So this one had a person in the middle, which really went down well with people. People like that. And the themes in the model were more about what might be happening to a person at different stages in their life. So you've got the green area about supporting people to just stay well and be healthy. The blue area around looking after people who might be living with a long-term condition. And then the bottom two areas about responding if you're not well or if you have an urgent or emergency need. And this model also talked a bit about the sorts of things you might need to enable the model and the sorts of teams you might have in place. So we spent some time going around the three places and essentially getting onto the agenda for any of the big groups that were meeting that we could get onto, talking about these three models and trying to figure out what people liked about them all. And then we just went through a process of essentially of co-design, of going around those groups again with different drafts of a potential future model for the whole system. And this was where we started. So this was 10th of September last year. This was our first draft. So we started with the idea of having a community in the centre of the model rather than a coordination service or an individual. We included the mission statement of the ICS, which is working together to empower people to lead their best lives. So you can see that there. And we also included the idea of the life course. So a lot of the communications and the strategy development in BSW has talked about the idea of supporting people to start well, to live well, and to age well throughout their life. So we wanted to include that there. We were trying to represent things like all the different partners in the ICS on this model. So you can see there's hospitals clearly represented. Something might look a bit like a GP practice in the middle, a town hall. We tried to represent the idea of technology with that blue kind of ribbon going around the outside, and the idea of coordination at the top there with a sort of person with that kind of call center mic on. And we were trying to represent something of the variety of geography and different places that there are in BSW. So, you know, there's something that looks a bit like a more rural farm type location in the bottom left there. We got loads of feedback on this. This was just the first go, and there was a lot of feedback on the language we'd used, on the way it looked, on some of the way we were describing things. For example, at the top left there, you can see a box that says keeping people well, and people reacted quite strongly to that. They didn't like the idea that health and care services were here to keep people well, like it was something we were doing to people. We want it to feel a bit more like enabling people to live healthy lives rather than being paternalistic about it. So we moved on to a second draft where we tried to bring in the idea of the themes that we'd seen in some of the other models that we talked about from Bath, from Swindon and from Wiltshire. These were the themes we tried in this draft. So we have a theme around improving health and well-being, a theme around coordination, which wasn't just about coordinating services for people, but it was also about coordinating things between services and really making the most of being an integrated care system and being able to coordinate things, you know, behind the scenes. We tried something around a theme about things being much more local, so about services being provided more locally and about things being more directed around the places where people live. And we came up with a theme about facilities of the future. So not just facilities like hospitals and buildings, but also thinking about investing in digital technology and in the workforce to create the facilities we need for the future. And again, we went round, we got a load of feedback, and we took it onto another draft. And I think it was from one of the discussion sessions on this that somebody forwarded me a model that they'd seen from, I think it was from Camden CCG or somewhere in London, where they had families in the middle and then a kind of concentric rings of services going around them. Apologies if you're seeing all these project and program management messages. I was invited to another meeting I've not gone to, and obviously things are heating up on the chat there, so I'll just have to bear with those, I think. But we started a draft there for the for BSW around that idea of concentric circles. This was the draft we knocked up to take back to a few groups, and people really like this idea about having the having BSW communities in the centre, surrounded by the sorts of things that will support them. But there were two main things people said about this. Firstly, the way this was laid out could look like that outer ring with the specialist centres was like the biggest ring, and it might still dominate in the future. And that was absolutely not the idea we were trying to convey. So there was some feedback about adjusting the way that the real estate was kind of laid out in this model. And people felt really strongly that although it's good to see the community represented, we should still have a person in the middle, because everything should be about personalised care in the future. So that took us to our first draft. This was version 1 of the model, which we finished around October last year. In fact, it was October the 7th. I remember the meeting we had about it, where we kind of launched the model. And we ended up with our person in the centre representing personalised care, the person living in a healthier community, which is supported by joined up local teams. Then there are more local specialist services available when people need to be referred for specialist care, and there are specialist centres there if you need them. But hopefully the idea with those two big arrows at the top is that actually as much as possible is happening and being supported in the community you live in. This was version 1, and what we then did in November and December last year was a 6-week period of public engagement to get feedback from people on this. And our public engagement went really well. Bearing in mind, last November and December, that's when the Omicron variant of COVID started circulating. So there was a bit more restriction again about being able to get out and about. Most of our engagement was done online, although we did do some in-person meetings, particularly with specific groups we wanted to engage with. So this was led and managed by a colleague, Martha Cox, who went out to meet groups, for example, groups of asylum seekers, groups of mothers and babies, and groups that we really wanted to contact about this. Overall, we managed to reach just over 1,400 people in our engagement events in 6 weeks, which we were really pleased with. And we managed to get over 900 people to fill in an online survey about this. So we got a good chunk of data back about what people thought about the model we developed and what was important to them. And these were some of the key messages we heard back from people. So all in all, there was strong agreement with some of the key points we were trying to bottom out in our development of this. A lot of people agreed that coordination was important. It helped to join services up. People talked a lot about things being fragmented in their feedback. They really want us to all work together. So the idea of an integrated care system, bringing NHS, local authority and third sector or voluntary and community social enterprise sector together, people really liked and agreed that's important. They want more things available closer to where they live. They want things to be more personal. And the idea of working with communities on the strengths they already have and building on those, people really agreed with. There was support overall for digital technology, but I think, on the next slide, just some of the other feedback we heard from people. Overall, people support the use of technology, but there was some real concern about not going too far with technology so that we exclude people who either don't have access or can't use digital technology. In the first version of the model that we used in the public engagement, there was a section where we said we were going to use digital by default, and people really didn't like that because they thought that came across like you'll never be able to see a doctor in person again. You're only ever going to have video consultations, and that's absolutely not what we meant. So we changed that language in the final version. People raised concerns. Well, people had questions about whether the model included mental health provision as well as physical health, and people also asked, does this include children as well as adults? Is this about everybody? So we made sure in the final version that we were really clear. Yes, this is about all health. It's about everyone in the population. People had on those kind of third and fourth bullet points there, people went really quickly to questions about how are we going to actually deliver this. So members of the public are really well aware of the workforce issues we're facing in health and social care and of the financial issues we have. So quite a lot of people said, this all sounds great, but how are you actually going to do it? And they really want to understand the detail. And people had quite a lot of questions about what it would mean for them specifically, understandably. So people were asking, what does this mean for me as a carer, or for me as a person with this particular condition, or for me as a resident of a particular town or a particular village? So overall, what we took from this was that people actually were really pleased to be engaged in a conversation about this and want to stay engaged. So as the detail of transforming health and social care in BSW is developed, people were really keen to stay involved. So we took all that feedback and updated the model based on what we'd heard from people. And so this is now the current version of the BSW care model, version 1.1. There are some changes to the way we've laid out the sort of key image of the model. So we still have our person in the middle, and it now says personalised care, because we wanted to make sure people understood what that meant. Our healthier communities and our joined up local teams are part of the same part of the section of the model, if you like, now, because actually, the idea is that we have joined up local teams supporting people based in the communities where they live. So it made sense to put those things together. And there are some other changes around layout and the things we're trying to represent here. This, I still think this could be further developed, and the idea is this is a living thing that continues to develop as BSW Together develops. But this was the version we landed on after our engagement, and there's just a couple more slides for me to talk through about what this model. So we in the final version of this, we've absolutely clearly clarified this is a model for the whole population of BSW, for the whole life course. So we've already talked about starting well, living well, and aging well. But quite a few people really wanted us to be clear that this is about the end of life as well and about dying well. So we've included that in our description of what the model is about. And this is absolutely about all aspects of health and care. So that's about physical and mental health issues, but also social care. And it's also about starting to address the wider determinants of health, things like access to education, transportation, housing, and so on. And these are the 5 core parts of the model. So the idea of this is that, the model provides a single shared strategic vision for BSW Together as an ICS. And these are the 5 core things that we want people to be focused on in the development of the ICS. So first of all, personalised care. We want every aspect of health and care to become personalised for every person who needs to interact with it. So whether you're, a generally healthy person who wants to seek some health advice, that should be available in a format that works for you, whether that's a different language format or a different way of accessing it online or on paper, or through appointments, right up to if you're somebody living with multiple complex conditions that's interacting with loads of teams. For you, personalized care might mean that you've access to named teams who know you, that you have your own budget for managing your care yourself rather than getting what you're given, that you have a personalized health plan that you've been supported to develop, and people know how to help you if if you need support with your condition at different times. So personalized care being absolutely central to everything, no matter where you are in the spectrum of needing support from health and care services. The second part of the model was that we want everybody in BSW to be living in healthier communities. So that really gets to grips with the idea of the wider determinants of health, that the place where you live can either help you or not to be a healthier person. So that's about getting to things like, where you live. Is it easy to ride your bike or walk to work or school, or actually are there no cycle lanes and is the traffic really awful? Where you live, can you access a green space if you want to exercise? Can you access education and training or social clubs and things like that if you want to make friends or learn something new? Is it easy to buy fresh fruit and veg where you live, or is it not? We really want to have the model focused on those parts in the healthier communities bit, so that people can live healthier lives, and we start to address the prevention agenda through that. The third part of the model was about having joined up local teams, and the 2 parts of that, joined up and local, were really deliberate. So the idea with joined up is that in your local area, the teams can work together, and it doesn't really matter who employs the people in those teams or what their badge says, but that when they're working together, people are able to share data, they can work in each other's buildings, they can use each other's equipment, their training is accepted by others, and their assessments of people are accepted by others in a team, and so on. So the joined up bit, making that really seamless between health, social care, voluntary sector, and others who might be working together. The local part, that's about making sure that local teams are tailored for the specific part of BSW they're supporting. As Richard said in the introduction, there's some quite significant inequality across the BSW patch, from really wealthy areas and places like Bath in their system to much more areas of fairly significant deprivation in Swindon and in some of the towns, to really rural areas where people are quite isolated and access to services is pretty challenging. So the local teams that we might set up in those areas might need to be really different to address the needs of the people living there, and that's absolutely right. So this is having one model for BSW means one size fits all. The idea is that there should be joined up local teams that are exactly right for the neighbourhoods and the places that they're serving. Then we have local specialist services. So that's the idea that there should be much more access to specialist services when you need to be referred to something closer to where you live. And that's whether that's through consultations at home, maybe that's a home visit, maybe that's a digital consultation if you want to have an appointment online. You might be able to go to somewhere like a GP practice or a community centre to have an appointment rather than going all the way to a hospital. And it's about things like the new community diagnostic centres that plan, so having access to things like MRI scans and endoscopy much closer to where you live rather than having to go to a big hospital. And then finally on the model, the future is absolutely includes specialist centres, and we don't just mean specialist centres like NHS hospitals, but also specialist centres in BSW run by the third sector, for example, the hospices in BSW, and specialist centres run by the local authority and other partners, children's centres and so on. So the specialist centres are really important, and people should absolutely have access to those when they need them. So that explains the 5 parts of the model, and just for the last few slides of the presentation, I'll hand back to you, Richard, to talk a bit more about how how you're going to deliver all of this in BSW Together.
Yeah, thanks, Geoff. And I'm conscious of time and people will have commitments, so I'll keep this fairly brief. All of this work was being done, as everyone knows, at a time of massive change. So Geoff put up a great slide showing how many people we engaged with and what have you. But in a way, we've had a massive turnover of our sponsors at system level, and we've had, you know, a population of 1 million people. Even if you get 1,000 responses, it's limited. So we've still got a long way to go. As Geoff says, this is a conversation at the beginning, not the end of the process. What we are beginning to get into is what does this really mean? So what will it mean in terms of the way we organise ourselves? And you may remember earlier in the deck, Geoff showed a complicated, if you like, an architecture type diagram showing how the bits fit together. I think we're now returning to that bit of the conversation and saying, what will care coordination look like? What will an integrated neighbourhood team look like? And that might look really different in central Twerton in Bath as it does to, you know, rural parts of Wiltshire. So we're getting into those conversations, but we're, you know, it's not as if we've got the whole of BSW absolutely behind us. We're having to sort of reconnect with people as we go and take them on that journey. And I suppose the sort of final bit to sort of touch on is colleagues will be familiar that integrated care systems are required to produce an integrated care strategy later this year and early next year. So what we're hoping very much is that what this becomes is an integral part of that strategy. It sits at the heart of it, and it enables us to sort of leap forward, if you like, into so what will that actually mean? So we don't have to debate again the basic principles of what we're trying to work towards. Those are well defined in this model. And I think the final point for me really is, if you listen to the story Geoff has just told, the value almost isn't in the product. It's in the conversation that has taken place. It's the dialogue, it's the thinking and some of those things. And I think what we've been able to do is have a bit of an honesty and a bit of a conversation. And although that's been challenged as we've had so much change and turnover, it's also laying some of the foundations for the future, really. So having the courage to have an open conversation. And I think what you heard from Geoff in particular that really stood out in his piece of work was the ability to listen and the ability to change. You know, we weren't stuck in our ways and holding on to something. We were really genuinely engaging and listening. And I think that set us up well. And we now have colleagues from SCW coming to support us, I think, with the next stage of some of our engagement around integrated services. And that will be a great example to build on this work. So, Geoff, I'll draw it to a close there. I'm really happy to support any questions or anything if people have got them.
Thanks, Richard. If anybody would like to ask a question directly, do put your hand up.
Tony's popped one in the chat about interoperability. Yeah, Tony, it's a huge question, isn't it? Because, you know, we can spend an awful lot of money and doing some of these things. And I think it's a mixture of the sort of macro and the micro, I suppose, would be my response. It's everything from, you know, QTPR, electronic patient record programs, where we're trying to get consistency within the hospitals, through to, you know, what we're doing with a shared care record and how we use that. So we've been doing a lot of work recently in rolling out our shared care records into social care, into mental health, into other parts of our system. So I think we're, again, you know, that's a long-term journey, isn't it, of change. And it's not just about the technology, it's about how people use it and all of that. So it's a big part of our program, because if we're genuinely going to offer our personalized care and integrated teams, at the heart of it, as your question implies, really that technology is critical to it.
We've had a question from Jill about how people react to personalized care and the idea of managing a budget if they're not really used to considering the cost of treatment. I think that's quite an interesting one.
It's a great question, isn't it? We're still a bit paternalistic, aren't we, in health and care services? And, you know, it's going to be a brave new world. You know, how do we take a £1.6 billion spend health and care system and allow people to spend that money themselves. You know, that's a huge giving up of control. But actually, if the outcomes are there, so I think we're again at the foothills of that journey. But I think increasingly we'll see more proportion of our budget being shaped in that way. So hopefully that's helpful. Geoff, I'm conscious we are up on time. I don't know, was there one other question there?
I think that was a thanks in the chat there. So, well, thank you everybody for joining the call today. Thank you for joining us to talk through this. It was a great piece of work, and it's good to be able to talk through it again. So we will make this available online, and if there are any other questions, please do contact us after the talk today. Thanks very much.
Thanks all.
Bye everyone.
Thank you.
Thank you.